When our behaviors are a problem, safety is a primary concern. And when we think about safety, you know, fall risk is a big one, right? So you could have problems around stairs in your house. The oven and heating plates and heating appliances are always worrisome. Hot water bottles are worrisome. Plugging in these electric appliances are worrisome. So it's almost like you got to make the house safe. So if the person is getting frail and they tend to wander, you want to have lots of night lights around, because you're going to be asleep some nights and they're going to get up so that they can see. Depth perception, we know, gets thrown off with dementia, so it's very important that we have contrast in colors and we don't have glares. So if you've got really glary linoleum floors, you can't really judge the depth. Plus the other thing is, if water gets on it, you can slip on it, you won't see the water. So you want to have more pastel colors. At the same time, in terms of your area, you don't want a cluttered area. Because if you've got in your bedroom lamps and coffee, you know, end tables and whatnot that have sharp edges, anticipate the fall, so you'll know how to protect the person if they should fall, right? So if you've got stairs in your house, sometimes there's little tricks you can use. You know the yellow police tape? Put the tape across the doorway. The person will come up to the tape, won't go past it. It's really interesting. The other things, sometimes with certain types of dementia, with Parkinson's and stuff, you can put lines on the road. You put lines, tape on in your kitchen or around your house, and they'll follow the lines. These are things you can do to get the person in a behavioral pattern so they're not deconditioning, because if you can keep the person in a high level of physical function, generally speaking, their behaviors are easier to handle. Anybody in the audience have any issues of safety that they would like to talk about? Driving is a big one that comes up. That usually comes up in the early stages of dementia. So by the time we get into middle dementia, most people have had their license suspended. But it can be a problem in communities, and we've had some patients where they're out there driving and you have to report them. You have no choice. And as a responsible citizen, you have to report them. So that can be a hard one, especially for us, because if we get the blame for being the bad guy, we're thrown out as the caregiver that turned them in. And yet they need our support. And we're trying to act on behalf of the government, which has put this responsibility in our court, but really it's the government's that grants the privilege for driving. The driving is always a hot issue when it comes to the early stages of dementia. The more in the middle and late stages, the real issues are safety. Can the person be left alone in the house? Or, you know, are they safe around, you know, in terms of falls, or in terms of danger around oven or hot water or whatnot, bathing, these sort of things. So you really need to have a close look at the house and environment, if you can afford it. There's an occupational therapist is a really invaluable person to come in and do a home assessment. Because the occupational therapists have spent their lives learning how to make environments safe. So they can walk in your house and notice that carpet's a bit slippery in the hallway. There was one, and I got to tell you a little bit of a funny story. One of my colleagues did a house call one time here in downtown St. John's on a patient with dementia. And people with dementia learn how to behave in their homes. Especially if they've fallen enough times, they learn to avoid the thing that's causing the fall. Because you have dementia doesn't mean you're not capable of learning. So my colleague went in, knocks on the door, there's nobody comes out. He knocks on the door, nobody comes out. Rings the doorbell, nobody comes out. Touches the doorknob, door opens up, so he walks in. By this time, this lady who was demented is coming out. She walked down over the stairs. She was upstairs. She walked down over the stairs, and she was going like this by the wall. And Bill is watching her, my colleague. She's walking along by the wall like this, shuffling by the wall. And he says to her, why are you walking like that on the wall, like that? Oh, she says, if I walk on the carpet, I slip and fall. But she didn't have the intellect to put the carpet up. It was like a concrete response. A frontal lobe dementia, the concrete response, and they respond in a concrete fashion. So her solution was not to walk on the carpet. So just walk. Rather than you or I would take the carpet, roll it up, throw it out. So safety, primary concern. Bathing is a big area. And in the nursing homes, for those, the LPNs in the audience, where you're going to be at the greatest risk of being injured is in the bathroom with your resident. The reason for that is miscommunication can take place very easily in that setting. Because how many of us feel comfortable with a stranger watching us when we're naked? And the answer is numbness. That's exactly what you're going to be doing in a nursing home. So how you approach the patient and your voice and your tone and the water temperature and making sure you're bathing them at a time when they're used to being bathed. So if you say, oh, schedule today is I got to get up and we got a busy day here, 8 o'clock we're going to do Mr. Brown and 9 o'clock we're doing Mrs. White. Might work that way because if Mr. Brown never bathed until 10 o'clock at night, you got a problem. Your scheduling has to fit the patient. The patient can't fit your scheduling. With dementia, people can't change how they react to you, but you can change how you react to them. Your schedules have to meet their needs. The challenge for long-term care is that we have all these individual plans that need to be met, and you have an impossible task to do with the number of people you're related to. So you do the best what you can in those circumstances. But remember, the most dangerous place is in the bathroom. And when I look at the violent episodes that we have in our unit, today we're talking about rounds on rounds. It comes up again today. Mr. So-and-so is upset. Tell me the circumstance. Tell me the antecedent. Tell me the environment. What happened? Oh, we're in the bathroom again, Dr. Butler. And I say, okay, what happened? And then you break it down and you try to figure out a plan. And you try to use the behavioral stuff first, and then sometimes you do stumble onto medications if you have to. But generally speaking, as a caregiver working in the nursing home, remember the first approach to behavioral problems with a patient with dementia is a behavioral interventional plan. It is not medications. Medications don't work very well in this scenario. The thing that works the best, the thing that works the most consistently is behavioral interventions. So you have to get really, really smart on reading nonverbal communication. As dementia progresses, reasoning and language skills are gradually lost. That's what I'm saying. Miscommunication. Communication becomes more behavioral. So what did the baby do? And I don't mean to infantilize people with dementia, but what did the baby do when it cried? Why does a baby cry? The baby doesn't have any verbal communication skills. Why does it cry?
Hungry. Maybe hungry.
Hungry. What else? What else does it cry?
Wet.
It could be wet and uncomfortable. Why else does it cry?
Pain.
Pain. Why else does it cry? 4 things. You got 3 of them. It's hungry, and it wants comfort and nurturing. Right? So, why should we be any different? That programming is still in that person with dementia. When they lose their language skills, the primordial skills that were engrammed into the brain at the beginning are still there. And they read nonverbal communication better than you or I do. Because we build up all these filters to hide out how we're emotionally feeling. We've been brought into society and we've learned how to respond in society. But people with dementia have total, they see right through the filter. So you got to be aware of that, because they'll read your nonverbal communication. And how much of communication is verbal versus nonverbal? So I'm here talking in front of you. If I'm saying, I'm really concerned, and I'm up here going like this, well, I'm really concerned about you guys here today, and wait, now I got a call. That shows that I'm not concerned. Your body language gives away every time. 90% of communication is nonverbal. 10% is verbal. The problem with us is we rely on the verbal communication skills, and we forget about what we're looking with our eyes. the person with dementia is unfiltered. They see with their eyes. In a strange sort of way, they are actually better at nonverbal communication than we are. So remember that one, because they will pick up on the nuances of your behavior. If you're agitated or frustrated, they will read it, and you will make them agitated and frustrated. You can walk into a room with a person with dementing illness who's calm and who's relaxed, and you can incite them into terrible anger very quickly by just the tone of your voice or by the way you rush through the room. And if you're not trained in the area, you can incite a behavior that can cause a co-worker to be injured. We had a serious injury on our unit, and one of the LPNs that went in before the serious injury, she came on the ship and she said to the nurse, the head nurse, "I'm really nervous around people with dementia." So guess what? She was put in the room on the plan that day with the most aggressive person on her unit, which was a bad thing. But she ended up, by some freak of nature, being in a room with him. She walked in there, she was terrified. He gets upset, she walks out. The next nurse, who knows him for years and years, walks in to do a simple maneuver and gets plowed. And the reason why she got plowed was that that person was set emotionally. And the next person that got in their range was going to get it. So you've got to be very careful that when you're feeling tense around somebody with dementia, you're having a bad day, you come into work, the baby is home sick and got a fever and you're worried about that child and you're in there on that floor, you really got to watch yourself, because the patients are going to pick up and read that emotion. Okay? Communication becomes more behavioral. It is our challenge to try and understand what the behavior is telling us about feelings or needs. Behaviors are not done on purpose to annoy us. Okay? They're not done on purpose. Sometimes you think they are. That person, he really knows when he did that to me the other day and he got angry, he really knew what he was doing. Well, at some level, probably the person did. But for them to have insight into it in the moderate to severe stage of dementia, that's gone. So we have to realize we can change how we can react to the person with dementia, but the person with dementia can't change how they react to us. So if you're an LPN, I'm seeming like I'm picking on the LPNs today. If you're an LPN working in a nursing home and there's problems, and you're in there talking to a demented patient, telling them to stop doing something, I got to say, where did you get your training? I have to say that to you, because that person, by definition, if they're in a nursing home, most of them are moderate to severe dementias. They don't get there until they get, the number one reason why people get into nursing homes and there's problems is because the behavioral correlates related to they're dealing with the loved one that can't cope. The caregiver's burnt out. And it's always due to the behavioral problems associated with the dementia that burns out the caregiver, and the person ends up in an institution. So remember that one. Okay? Remember that. Okay. As dementia, so we sort of touched on those areas. Any questions about that? That's hard stuff. Yes, question?
So what about if you walked into a room and say somebody was doing something, would you just let them go about it and keep doing it? Let them keep doing it? Rather than step in and say, no, can you please stop that, or try to step in?
Very, very interesting. When you're the junior person on a totem pole, you're going to walk into some scenarios where you're going to see things going on that you don't approve of. What happens in institutions is very interesting. With caregivers that are burnt out, and we got workers in our nursing homes who are burnt out, they will do things, like for instance, they'll say, I'm not going to change that patient out, he was aggressive, I'm going to put him at the end of the list. Well, that's really not good. That person probably needs to be cleaned earlier on, but if they blame it on the institution, well, they fired so-and-so last week, we lost the manager, nobody cares about us, we're going to do our best we can, so what? That's all we can do. So they sort of justify their actions based on the political thing. So they download what should be a professional insult to them, to the system. So for the answer to your question is, you need to challenge your colleagues outside that milieu. And we have to develop cultures in our caring environments for people with dementia that allow the caregivers to openly speak about their feelings. Now, if you go into work and somebody's cursing and swearing on you all day long and swiping at you and whatnot because you can't figure out what what it is that they're trying to tell you. You can't figure it out. And believe me, sometimes it can be just like that. You have the smartest people in the world, we can't get there. And sometimes we got to resort to medications to tone the person down so that we can actually do their care, right? But if you're in that situation, you need to be able to come out and say how frustrated you are. You also need to have the protection in that caregiving group that you're working with, that you can freely express your feelings. Because if you can't get that out, that anger that you're bringing into the workplace will be reflected on the patients around you. So the answer is, you need to address it. I wouldn't address it in front of the patient, because when you address it in front of the patient, that conflict that you're going to generate will have a negative effect on the person's behavior. So get out of their line of vision, go somewhere in that place, maybe over lunch, and say, you know, I'm only new here. I saw how you did that. I noticed how it did that to the patient. You know, did you ever think about doing it this way? I learned when I was in the school that maybe if I can actually cause some of these behaviors, and maybe we should look at a different way of doing it. And if you've got good people around you, they will nurture you, and they will see that, and they'll see the strength in that approach, right? But it's all about approach. And in Israel, there was a big study done that tried to address this issue. And one of the things they said, we have to develop open cultures in our caregiving institutions. Cultures that don't point the finger and blame. Like when somebody says, oh, it didn't happen on my shift, so you know, I'm not to blame, thank God. Well, the fact that it didn't happen on your shift is irrelevant. You are a part of that person's care. And if the weakest point in that person's care had happened on, and you had knowledge of it, you're just as much responsible as anybody else. And if it does happen, you have a greater responsibility to sit down with the team and say, how can we get on and do a better care on this institution? How can we do a better job? We have a responsibility, right? So, it's tough. Believe me, being an LPN and working in institutional care in this province is a tough job. You've got to be a really smart person. You've got to have really good interpersonal skills. And you not only have you got to have a good heart, you got to have a really smart mind. Because I say to people, when you're working in these homes now, it's like an intensive care unit. The behaviors are so challenging, it requires really, really well-trained people. Now, some people get it naturally. You're going to have people in those nursing homes who naturally settle you down. I'm amazed at how some people, like 90 pounds, can handle 200-pound residents with ease. And it's because of the way they manage themselves. So you got to learn, when you're around that environment, who's the person that can deal with so-and-so on the floor and do a good job? Or who's the person in the home deals with it? Now, I noticed in my family, when so-and-so was in, he's perfect. But then when my sister comes in, he goes nuts. Well, what are the things that the person who settles them down is doing? Because that's the ones we got to follow. We got to follow and emulate the behaviors of the person that don't upset the person. That's one model. Rather than say, the person that's upset and what are they doing wrong, we probably never know, because the person with dementia is reading their nonverbal signals, and we don't pick up on them. So look at the person that we do know, and follow their approach to the T. And you know what? It works. It works. Sometimes it can be as little as, you know, how they approach the bed and turn down the sheets. Sometimes they go over like this, and how are you this morning? How are things going? Feeling all right today? And you settle them down, and then they go on with their care. Whereas the other person comes in, here, give me your arm, I'm going to just get this shirt off. Right? So rather than take the behavior that incites the response, take the good behavior and emulate that. So as an LPN, you've got to be really observant, watching people how they do things. That way you will be safe, and you will learn how to deal with difficult behaviors. So hopefully it's a long answer, but hopefully it gets to where you are. It's a very perceptive question you ask. Okay? Good one. Okay. Behaviors are not done on purpose to annoy us. People don't do things on purpose with dementia. They do it because they're trying to tell us something, and we're misreading it. We're misreading it. And I remember when I first got introduced to this game, there was a guy, Len Fabiano. Some of you may have heard of Len Fabiano. He ran a company where he used to go into nursing homes, and he would be like a patient. He said, I'm going to go in now, and I'm going to be here for 48 hours. And he'd live in the nursing home with the patients, and he'd have people treat him just like, and he'd watch what was going on, and he could see all the shifts, and he could see the behaviors. And I remember Len came down to our institution, and I watched him in action, you know, and I said, He said, you know, these are really good people you got here, he said, but you've got some really challenging behaviors in the residents. And he said, your environment is part of the problem. The way we have our institution built, we don't have the space or the design to let the people wander appropriately. We're having people who have dementia wandering into cognitively well people's room, and then the cognitively well person gives an aggressive response because it's their space and they don't want somebody to open their night table. So guess what happens? In our nursing homes it's like that, eh? We got people with dementia in rooms with people who are cognitively well. And we've got to get smarter at saying, you know, guys, this is only going to cause conflict. We've got to learn to group our patients to their needs. If we group the patients to their needs, and we train the staff to the types of dementia they're dealing with, we can have a much better functioning institutional environment. Okay? And same way in the home. When you're home, knowing how to respond at the various stages of dementia to the person's problems is really important. So if you got a person with advanced dementia, early on in dementia you might be able to take them and lead them around because they'll follow you. Later on in dementia they may resist you. So then you may have to find other ways of distracting them. So you might have tasks that you've set out for them. So when they're out there and they're in a mood, they're getting off, you might just go out and the old towel folding one, right? Bring the towels out, lay them down beside them, and start folding towels. And they'll do that for hours and hours and hours. With men, it could be, you might have something there. If he was a carpenter, you might bring out some pieces of wood for him to look at, or some joints or something that you can fool around with, and that will take his attention away for hours and hours and hours. So you got to find out what that procedural skill is that you can use for distraction. And that's the art of it, finding the procedural skill that you can take them over to. Questions?